welcome to the CS4 lecture on the history involving the genitourinary system. And because this is a really broad topic, because we're talking about the kidneys, the ureters, the bladder, the function of those things, we're also going to have to talk about the reproductive system and the history involved in addressing symptoms and complaints that are going to relate to the reproductive system. So we're going to divide this up into a couple of different lectures because I don't want to do too much in any one lecture. So for this lecture, we're going to focus in on the urinary system, the kidneys, the ureters, the bladder, the urethra, and we're going to talk about how do you take a history related to those topics. As always, as I remind you guys each time I give a lecture, we want to start with the right mindset, the right attitude in our hearts. We want to view things the right way. So we start with the idea that patients are valuable because, you guys know the answer, God made them. And so when we treat patients, we are doing so with excellence, with compassion. We are putting their needs and their desires ahead of our own. And even though, again, as I say all the time, I'm coming from a Christian worldview, you guys are coming largely from Muslim worldview, some of you from Christian worldviews and other worldviews. We can agree on these basic things. So these things are not limited to one set of beliefs. This is just right as we pursue medicine to view people this way. And it doesn't really matter where they come from, what language they speak, what religion they practice, what color their skin is. Our job as doctors is to treat individuals, people, human beings created by God, with dignity, respect, compassion, and with excellence, the best that we can do. Okay, that's especially important here because these are sensitive histories to get. And so you want to have the right attitude. It could be very easy to be judgmental in some of these situations where you're going to have to apply these history skills. And that's the surest way to cut off communication and to cut off relationship with the patient is to respond in a judgmental way, even if it's not with your words. Maybe it's just with your body language. Even so, the patient will sense that and close off and you'll be unable to help them. Okay? So, with that said, let's dive into this first lecture on genitourinary history. So a few cases to get us going. Maybe you're in the emergency room and you have a patient come in with abdominal pain of 2 days duration. Maybe you have a patient coming in with back pain. Maybe you have a patient coming in with altered mental status, especially an elderly patient, either male or female. Or perhaps you're dealing with a patient with no symptoms at all, but you have some laboratory values that are abnormal and that you need to address. Well, how could you get all of these complaints from one system? Well, the urinary system is that way. You have to remember that people will present in a variety of ways when they have problems with the urinary system. They may have abdominal pain. That could be either from, the lower abdomen, could be from the flank, the sides. They could have back pain, as you guys are probably aware. They can have altered mental status. One of the first things you want to do in an elderly patient who has acutely, in other words, new altered mental status, is to check their urine. Urinary tract infection is a common reason for the elderly to get altered mental status. But of course, you could also have uremia from complete kidney failure, and that would also give you altered mental status. But honestly, probably the most common presentation of a patient with urinary disease, urinary system disease, is no symptoms at all. Okay? Maybe you've uncovered a problem with routine laboratory testing for another reason. This kind of thing. So it's not uncommon for people to have no symptoms when you're having to deal with a urinary history. All right. So with those in mind, let's talk about how do we do this? What are these things that we need to consider as we go forward? So let's talk about the symptoms people can have. We mentioned pain prominently in those case scenarios, and of course you guys are very familiar with how to use Socrates, or Socrates as I might say, Socrates, to get a history of pain. Well, you're going to do that. I should not fail to mention that you're going to use all of the skills you've already acquired in history taking, and you're just going to apply them to the system. So you're going to get a good history of present illness, asking them questions. But of course, first you let the patient talk. You start with an open-ended question, and you let them tell their story. They want to tell you their story. They want you to help them get better. Therefore, they want you to know what's going on with them. And then you ask questions to further clarify things. Maybe they told you the site of the pain, but not exactly when the onset was. Maybe they told you what it felt like, but not exactly how long it lasted. So you are going to go through and ask those Socrates questions. And if it's not pain but some other symptom, you're going to still go through those same questions. You're just going to leave off some of them. Maybe the site doesn't apply because it's a more general sensation, that kind of thing. So just use all of those patient-centered, open-ended questions, affirming language and body language, verbal and nonverbal cues, signposting, summarizing, all of these skills we've already acquired. Let's use them for this. So now let's just talk about the specifics relevant to this system. So let's start with pain. What kind of pain do you need to be aware of? Well, there's what's called loin pain, and this is the pain in the back, the mid-back specifically, not upper or lower. And other names for this are renal angle pain or costovertebral angle, CVA tenderness, because it's at the costovertebral, so the joint between the ribs and the spine. The angle formed by those two bones coming together in a joint is where you tend to get pain relevant to the kidney itself. This is in the area of the 12th rib near the spine, and this is occurring due to stretching of the renal capsule or the renal pelvis. It's more of a dull ache, okay? And things that could give you this, infection of the kidney itself. So pyelonephritis, not just a urinary tract infection of the lower urinary tract or the bladder, but when you have pain, or sorry, when you have infection that's all the way up in the kidney. Okay, this could be because it came up from the bladder, or it could be because of bacteria circulating in the bloodstream from some other place. All right. Anything that causes stretch of the capsule will give you this. So if you have a polycystic kidney disease and those cysts are stretching the renal capsule, that's going to give you pain. This is an organ without somatic nerve fibers. So what you're really dealing with is this visceral type of pain. So kind of non-specific, dull pain related to the stretch of the capsule, referred to the back at the level of the 12th rib. It could be infection or abscess stretching out the capsule. It could be a tumor stretching the capsule. Any of these things could give you pain. Okay, that's one type of pain. Another type of pain is colic from the ureter, so ureteric or ureter colic. So one thing to remember about colic, when we say colic, we mean it's a restless pain. When people have it, they don't want to sit still. They rock back and forth on the bed, this kind of thing. So it can be located anywhere from the renal angle all the way around the sides to the flank and can even radiate down to the groin. And it's due to obstruction and distension of the ureter. So you think of obstruction and distension of a tube, we think colic, like biliary colic, so a gallstone in your bile duct that obstructs it and causes stretch will give you colic, restless type of pain. This is distinct from, say, somebody with peritonitis, say they have a ruptured appendix, and those people are going to stay very, very still. They don't want to move because moving exacerbates the pain. All right. So this is ureteric colic. They can also have dysuria, so pain when they urinate. All right. It's often associated with other symptoms like having to go to the bathroom more frequently. So you're putting out the same volume, but you're just going to the bathroom more frequently, emptying at smaller volumes. Or hesitancy, in other words, a difficulty in starting and continuing urination. This is going to be located in the lower abdomen or at the meatus of the urethra, so at the tip of the penis or at the end of the urethra in a female. But it can be associated with lower abdominal pain because of the bladder being inflamed. And of course, as I say right here, it's due to either the bladder being inflamed or the urethra being inflamed. So different types of pain at different levels that you need to consider. I didn't mention that for the colic, the most common reason for people to get this, of course, is a kidney stone. Nephrolithiasis. Lithiasis referring to a stone, nephro referring to the kidney. They have a kidney stone obstructing the ureter and causing distension and causing pain. And what's really causing that pain is a spasm of the smooth muscles of the duct because of the stretch. And that's why they get this spasms, episodic spasms of pain that are very intense. Okay, so different types of pain you want to ask about. Try to define what type of pain they're having. It will give you a clue about where their problem is and what their problem is. Okay. Also consider if you have pain localized to other structures related to the genitourinary system, say the penis or the testicles. This is going to be more specific. This is not a visceral symptom. This is a problem at the site. So you could have infection of the tip of the penis, inflammation for other reasons. You could have tumor, of course, any of these sorts of things. There are many other things that you could have. Or, if it's the testicles, you're thinking about a problem with the testicles. In young men, we worry about torsion of the testicle. And so this is severe, severe pain in the testicles. You can also have other things, especially in older people, like infection of the epididymis that sits on top of the testicle, or epididymoorchitis, which is inflammation or infection of the epididymis and testicle. And in young men, this tends to be a sexually transmitted infection that's causing it. In older people, it tends to be more like the urinary pathogens that cause it, which I'll cover in microbiology. And again, pain in these areas is not general or referred pain. It is strong local pain that they're having, and you want to be looking on exam later for what you might find in those areas. All right, so that's pain, but we also want to talk about some functional symptoms. So when we empty our bladder, when we get rid of urine, we call this voiding. And voiding symptoms come in a few varieties. One, you can get storage symptoms. So these are related to the bladder, right? It's a storage organ. And we mentioned earlier frequency. So you're going to the bathroom more often, even though your total urine volume is staying about the same. And this goes along with anything that inflames the bladder, infection or anything else. Urgency. So it's a sudden, strong need to pass urine. There's a commercial I want to show you in a second that demonstrates urgency. And then nocturia. And this means when you're waking up more than twice in the night to urinate. So this could be, again, from infection. This is just urinary frequency that's happening in the night and waking people up from sleep to take them to the bathroom. Okay, so it's frequency, specifically where this manifests beyond just infection or inflammation is, of course, obstruction of the prostate, where they can't empty their bladder fully. And so they have a pretty large volume of urine left in the bladder when they're done voiding because they require high pressure to pass urine. And they just have to empty more frequently because they fill up more frequently because they never get rid of everything in their bladder. This, of course, also predisposes them to infection. All right, so with that in mind, let's go to this commercial that they showed in the US a number of years ago that is for a drug for people with urinary urgency. And yeah, I think you'll see why I think this will help you remember what urgency looks like.
If you've always got to go, ask your doctor about Detrol LA. It's been proven effective for overactive bladder.
Need a break?
Not right now.
You shouldn't take it if you have stomach, urinary, or glaucoma problems. The most common side effects are dry mouth, constipation, abdominal pain, and headache.
And I don't have to go right now.
Detrol LA, when you've always got to
So
go.
perhaps you can see why I thought that video was so appropriate for our purposes today to illustrate that urgency sense. You'll never forget it, hopefully. Okay, so other voiding systems. Again, we mentioned hesitancy earlier. It's a difficulty in starting your urine flow or a delay in starting your urine flow. You can have really slow flow. So hesitancy could be for a variety of reasons. Could be inflammation, infection, could be from obstruction. Slow flow is going to be more so from obstruction. So again, we think classically in males are the prostate. There aren't very many things in females because of the anatomy to cause obstruction, but slow flow can be an issue. Incomplete emptying. So again, we think of obstruction primarily as preventing complete emptying, although again, perhaps inflammation and hesitancy could lead to incomplete emptying as well. So you can get those storage symptoms, voiding. So when the urine is just sitting there, you can have symptoms with the bladder. When the urine is moving, when you're voiding, you can have symptoms. You can have symptoms after voiding. So specifically something like dribbling urine, which again, the inability to stop the flow does tend to indicate some degree of residual volume of urine in the bladder, and so we think again of obstruction in that case. And then lastly, incontinence. So that extreme sense of urgency I mentioned earlier can be associated with incontinence. What does incontinence mean? It means an inability to retain urine. Urine is leaking out. That comes in two varieties. One is associated with that strong urge to go to the bathroom. So you get urgency followed by bladder contraction and urine leaks out. And you can see where that could be very life limiting if you're out in public, if you're at the store, if you're riding in a taxi and this hits you. And so that's why those medicines were so popular in America. But there's also stress incontinence. So urge incontinence is a spasm of the bladder. You get a strong urge and then you go a little bit. And stress incontinence is when pressure is applied to the bladder, you just can't hold the urine in. And so the classic example is women after they've born some children. Uh, those muscles of the pelvic floor are stretched out and somewhat weakened, and therefore they aren't providing the level of pressure at the bladder outlet that can keep fluids in, say, when you cough, when you laugh, when you sneeze. So again, you can see how this could be kind of life limiting also. And this can be addressed with what they call Kegel exercises, where you work to strengthen the pelvic floor muscles, or again, sometimes surgery to tighten up the muscles of the pelvic floor. Um, so I guess along those lines, we should mention in pediatrics uh, the whole issue of continence. So obviously, this becomes an issue most often at night, where we get wetting of the bed in kids. Things you want to ask about there are other things going on at the same time. Sometimes this is associated with constipation. Sometimes it's associated with renal pathology, of course. But most of the time, obviously up to a certain age, before school age for sure, many kids wet the bed. The biggest red flag or problem you want to ask about is, did they have continence of urine at night and then lose it? That's secondary incontinence, and that's usually a different cause than did they never have continence of urine at night. That's primary incontinence, and again, that's really common up into even the earliest school ages. Maybe even 10 or 15% of kids at age 6 still have some bedwetting at times. But the secondary incontinence, one of the things you need to always ask about is the stressors in their life. What are some things that lead to that? Well, I've certainly seen it in children when their parents get divorced. You can see it certainly after child abuse or something like that. Anything that's a stress to the child can result in this secondary nocturia, so urinating at night. And of course, obviously with all of the countries that are having immense levels of trauma around this region, Syria, Yemen, Iraq, all of these areas, people coming out of those areas will very frequently, children will very frequently have bedwetting because of the trauma they've suffered. So you always want to think about certainly psychiatric causes as well as renal pathology when it comes to secondary nocturia. Okay, so we also want to inquire about abnormalities of the urine. So some things to be aware of. Um, Polyuria, where you're urinating more than usual. You're urinating a high volume. Again, frequency from earlier was the normal volume, but polyuria is an increased volume. And you think about things like diabetes, where they get polyuria as well as polydipsia, in other words, drinking a lot, as well as polyphagia, eating a lot. Um, that happens there because sugar is pulling water into the urine and it's increasing the urine volume and dehydrating them. You can get primary polydipsia where people just drink and drink and drink and drink and drink water until the water turns, or sorry, until the urine turns clear like water. And they're just urinating off all of the free water they can because people are drinking too much. This happens sometimes in people taking antipsychotic drugs. Oliguria. So when urine falls off below 800 mLs per day, this is oliguria, and the volume of urine is decreased, and that may be for a variety of reasons. One of the ones we worry about, of course, is when renal failure is coming on, because that's an indicator that the kidneys are beginning to not function well enough to sustain the body's functions, excreting waste and getting rid of water and all of that sort of stuff. Anuria. In other words, when you don't urinate at all, so there's no urine flow, and again, that's a huge problem. Maybe the urine's there, it's being produced, but it can't get through because of obstruction, or maybe there's not producing urine in the kidneys, and of course that's renal failure. Okay. Other things that can happen, you can get air in the urine. That's typically if you have a fistula with the intestine or something like that between the bladder and the intestine. Um, Air will get in. You get air bubbles in the urine. That's abnormal. That may be associated with fecuria. In other words, especially if there's a fistula, say somebody with Crohn's disease and inflammation, a fistula is formed from the intestine to the bladder, or maybe it's a fistula that develops from the vagina to the bladder because of childbirth. It's a very common, very bad problem around the world when it can't get fixed. So you can have feces in the urine from the intestine. You can have air in the urine from either a vaginal fistula or an intestinal fistula. And of course, you can get blood in the urine. Um, and that can be for a variety of reasons. It can mean nothing. In other words, they're totally fine. Somebody could have blood that happens intermittently in their urine, so-called gross familial hematuria. In that case, they'll have a family history of blood in the urine. Um, it could be from kidney disease. So you could get post-streptococcal glomerulonephritis 6 weeks after a strep infection, and you get blood and protein and these sort of things in the urine. Um, a variety of things. And again, when you first find blood in the urine, certainly you rule out common things like infection. Um, you think about kidney stones. Certainly when you have a kidney stone, you will almost always find blood in the urine. These kind of things, but you do have to be careful and think through, okay, is this pathological? Is it not? Do I need to do further workup? Do I not? And you always need to do some level of workup to determine why this is. Proteinuria, so they won't see much with that. So you won't get much on history about that. So you're going to ask them about volume of urine, too much, too little, not at all. You're going to ask them about other things in the urine, like air, feces, blood. And then as far as other things in the urine, like protein, the teaching is you might see a foamy or frothy urine from protein in it, specifically albumin being spilled into the urine. But I will say that I have not really seen that, even in patients with massive levels of protein in their urine. So remember it, but probably proteinuria will be largely asymptomatic unless it's so bad that they begin to get to lower extremity edema because they can't hold fluids in the blood vessels anymore. The oncotic pressure is too low. Even up to the point of anasarca, full body edema. So proteinuria will typically be made manifest as far as other symptoms. They won't actually know they're having it in most cases. All right, so we've talked about some things you want to ask about specifically. Um, and you can go back and review those. You want to ask about if they're having pain, of course, the usual Socrates questions, but also ask them specifically, okay, when the pain is located in a particular area, you want to know, does it have that dull character located in the back? Does it in the flanks and radiating to the groin and very colicky? You want to be able to put those types of pain from the urinary system in categories to help you get to a diagnosis. You're going to want to ask about storage symptoms and voiding symptoms and post-voiding symptoms, as well as incontinence and perhaps even bedwetting, nocturia. And if it's incontinence, you want to know what type of incontinence they're having. And then you'll ask, is there anything else in the urine that they're seeing, whether it's blood, whether it's feces, whether it's air, blood being the most common one you're going to come across. You want to ask about the urine volume, too much, too little, not enough, or not at all. And of course, do a good review of systems. So how do we put all of this together in terms of a history? Well, you guys know, again, the basic structure of the history. You're going to go through the chief complaint and on to the history of the present illness, letting the patient tell their story, going from open-ended questions to closed-ended questions, egging them on with verbal and nonverbal cues, that kind of thing. And then you're going to do some signposting and move on to a review of systems, other systems that may be involved. Obviously, if they have pain, you think it might relate to an infection, of course, you're going to ask about fever. If they have polyuria and you think they might have diabetes, you're going to, of course, ask about weight loss. Okay? These kind of things. So review of systems. So let's go into that. How do we take a history in this case? So get the chief complaint and let the patient tell their story. We've already said that. Of course, as I said, the history of present illness, when they started, what other problems are they having? What are the aggravating and alleviating factors, the exacerbating factors, the alleviating factors, the E in Socrates, etc. Then review of systems, you are going to make sure you ask about pain. If they don't mention pain, and again, if pain is the main thing they're having, they'll mention it. That'll be their chief complaint. But if they don't mention it, do ask, are you having pain? And then get a good Socrates history on that pain. Do ask about changes in their voiding. Do ask about the character of their urine. All these things we've already talked about. As far as other things we haven't really talked about, so past medical history. So hypertension and diabetes are the two leading causes of renal disease, renal failure worldwide. Ask about whether they have those for sure. Vascular disease. So one of the big reasons that you have problems with the kidneys is vascular disease. And that could be secondary to hypertension or secondary to diabetes, but also could be thrombotic, could be stenosis or narrowing. You just ask about these things. Certainly, see if they have symptoms of UTI now. Ask them, have you had UTIs before? And if you have, what did that feel like? Does this feel the same? And what was done to treat it? And how effective was that? And if they're having frequent UTIs, maybe you have to do something to prevent future UTIs, that kind of thing, urinary tract infections. Certainly, if they have a stone, you think, ask, have you ever had stones before? The vast majority of people who have a stone will have another stone at some point in their lives. And hopefully the doctors have told them to drink lots and lots of water and to limit their salt intakes, to reduce the frequency, reduce the risk of future stones. But nonetheless, somebody who has a stone is likely to have another one. And again, stones come in different types. That gets out of the realm of history. But if they know what type of stone they had on past medical history, ask. If they don't know, no problem. You're going to do some analysis to find out so that you can hopefully prevent them in the future. And then, of course, surgeries. Any surgery on any of the tissues of the urinary system you want to know about. Okay. Medications. So there are a lot of reasons you might want to know about medications, but there are two that I'm going to highlight here. One is drugs that they take normally may be metabolized abnormally when they have kidney disease. So, a good example is when you give somebody vancomycin for an infection. Perhaps they need that once a day. Perhaps they need it twice a day. It depends on their metabolism of the drug, right? Well, the metabolism is definitely affected by kidney disease so that sometimes you give a dose of vancomycin and then you're checking levels and you don't give another dose for a day and a half, 2 days, until the level falls to an acceptable amount. So you want to know, especially if they're taking drugs all the time and their kidney function starts to decline, you're going to want to know how to adjust those medications to make sure they don't have further problems from side effects because they aren't clearing medicines as quickly. Insulin's a good example. Diabetics, when their kidney function starts to fail, they need less and less and less insulin because they're holding on to the insulin they're taking longer and longer and longer. Or sulfonylurea drugs very commonly lead to hypoglycemia because they just can't get rid of them as easily as they used to when their kidneys aren't working. Okay, so another class of medicines you want to be aware of are those associated with causing renal disease. So if the drug is their problem, you want to know, are they taking anything? Have they taken anything that might be leading to the kidney problems they are having? So I mentioned vancomycin. It could cause kidney disease if it's too high. Macrolide antibiotics, streptomycin, gentamicin, can cause kidney disease if dosed improperly, or if there's already pre-existing things. Or some things lead to, allergic reactions that affect the kidneys, so-called eosinophilic kidney disease. So, yeah, just want to ask about the medicines they're taking and see if they're associated with renal disease, causing renal disease, or whether they might need to be dose adjusted because of kidney disease that you're seeing. Of course, their family history. Do they have kidney problems and urinary problems in the family, especially genetic conditions that lead to renal failure? So like adult onset polycystic kidney disease, that's that first APKD there. You want to ask, okay, go back, sorry. So you're going to ask about adult onset polycystic kidney disease, Alport syndrome. So they have a family member who became deaf and had kidney failure in their sort of mid-adulthood, their 30s and 40s. That might portend something bad in a patient with blood in their urine, say. They might be going to get Alport's syndrome. So, of course, also ask about family history of diabetes, hypertension, vascular disease, because that can affect this patient as well. And then other things, your social history, of course, their occupation, what do they do? Are they exposed to things that may damage the kidneys? Smoking. Smoking is bad for everything, as you guys know, bad for the lungs, bad for the heart, bad for cancer in terms of gastric cancer, bad for kidney cancer, bladder cancer. Another thing that's really bad for is just your kidney function. If a diabetic smokes, they are going to develop kidney failure much, much faster than somebody who doesn't smoke and has diabetes. And so you want people to stop smoking, period, no matter what. But one thing to be aware of is it can affect the kidneys as well. Ask about their alcohol intake. Alcohol doesn't affect the kidneys too badly in most cases. What can affect the kidneys really badly is if someone is an alcohol abuser or dependent on alcohol and they can't get it, and they take something different than drinking alcohol, but say rubbing alcohol or antifreeze, ethylene glycol. These kind of things, of course, can lead to really, really bad problems because your body metabolizes those things into very toxic metabolites. And of course, you can get multi-system organ failure, including kidney failure from those. And their diet in general. High intake of red meat is hard on the kidneys. That kind of thing. If they have kidney failure, kidney disease, you want to reduce certain things they have a harder time getting rid of. So things like phosphorus. So you tell them to drink clear sodas, not dark sodas like Pepsi or Coca-Cola because of more phosphorus in them. You want to be careful with their protein intake. You want to be careful with their salt intake particularly. Or like I said with kidney stones, you want them to drink lots and lots of water and reduce their salt intake if you want to reduce the risk of future kidney stones, that kind of stuff. So that's, of course, everything. That's all in brief. There are lots of other things you may want to know about. But this is just to give you an overview and to get you started on how do you take a history about urinary system disease. And then from there, you move into physical examination, and then we'll have a later lecture on that. And we'll have a later lecture on other investigations, diagnostic testing as well, that I'll do a little bit later to walk you through how do you evaluate your findings from history and physical examination with further testing. So thank you very much for paying attention. I hope this is helpful. I look forward to seeing you in the lab where you have a chance to practice these skills with one another on some case scenarios. And if you have any questions, as always, feel free to email me. My email is joelv@hu.edu.jo. And I look forward to seeing you guys soon. Thank you.